can see a life together, standing by you, and I think I want to forever. And after all that's come and gone through all the years, I can't believe the moment's finally here. And you never looked so beautiful. You're everything I've waited for, and so much more, standing right in front of me. And we could weather every high and low. If love is going where we go to have it hope forever, let's start our life together. Let's start our life together. Let's start our life together.
Good morning, everyone. Welcome to another Child Evidence to Policy and Practice webinar. I am Shang-Chi, the Head and Senior Consultant of the NUH Child Development Unit, and I'm also the Deputy Director of Practice and Partnerships at Child. Now, many people may not fully understand what developmental pediatricians do. We not only see children with autism, ADHD, and neurodevelopmental disorders. Now, way more than that now, developmental pediatricians are promoting developmental and behavioral health. This comes from collaboration with families, educators, therapists, and other healthcare providers to promote physical, emotional, and social development of children holistically. So with me today is Professor Carol Weitzman, who does that a lot. She is our Wong Hock Boon Visiting Professor at the Department of Pediatrics. She is a developmental behavioral pediatrician and the co-director of Autism Spectrum Center at Boston Children's Hospital, and also director of the CT Center for Developmental Pediatrics. She is an associate professor at Harvard Medical School and also professor emeritus of pediatrics at the Yale School of Medicine. Now, nationally, she is past president of the Society of Developmental Behavioral Pediatrics and past chair of the American Academy of Pediatrics section of DBP. Professor Weitzman is author of the AAP Clinical Report on Promoting Optimal Development Screening for Behavioral and Emotional Problems. She has served as principal investigator on many federally funded research projects and has authored national policy statements. Her research seeks to reduce disparities in identifying and treating children with neurodevelopmental disorders and to create healthcare environments that are safe and accessible for people with NDDs. So I am very pleased to have her today with us on this webinar. She is going to talk to us on this topic, Are the Kids Okay? Promoting Resilience in a Time of Crisis. Over to you, Carol.
Thank you so much, Shang-Chi. I am so delighted to be here, and I'm delighted to speak on this topic this morning. So today's talk is called, Are the Kids Okay? Promoting Resilience in a Time of Crisis. And I think we'll decide as a group, are the kids really okay? And we'll sort of think about that together. But in some ways, I also feel like the question really, the better question than even are the kids okay, is how can we ensure that the kids are okay? And that's what we're going to spend a lot of time talking about, is looking at what the state of things are currently with children. Obviously, I will speak mostly about the United States, but I will look at this from a global perspective. And also, though, thinking about what should we be doing right now, right here, today, to ensure that our children are okay and can grow up to thrive and be healthy and to flourish. So I have nothing to disclose. And this is what I'm hoping in our short time together we can accomplish. One is we should just understand the epidemiology of mental, emotional, and behavioral health problems in youth. I may refer to them as MEB problems, just to shorten it a little bit. Number two is understand the science of both adversity and resilience. And number three, identify simple interventions that we can all be thinking about, both on the individual clinician level and then on the larger policy level to enhance resilience and flourishing. So let's get started. So approximately, hang on a second, approximately 20% of children, based on the National Survey of Children's Health, show developmental MEB problems at any given time. And that can range from anywhere between 15 to 60%, depending on relational and social health risks. Now, if we break that down a little bit around looking at MEB problems, what we see is, again, based on a 2022 report that came from the National Healthcare Quality and Disparities Report, that approximately 4.4% of children suffer from depression, 9.8% ADHD, 8.9% behavior problems, and 9.4% anxiety. And 50% of adults report that their behavioral health problems had origins in childhood, first manifested during often adolescence, but often earlier as well. So we know that the problems that are showing in children many times often will continue into adulthood and are not transient. Now, we also know that these problems start early. 1 in 6 children ages 2 to 8 have a mental, behavioral, or developmental disorder. So I pause here for a moment for us to just take in these statistics and say, I say this all the time, we should not get used to these numbers. These are incredibly high prevalence rates, and that every time we see them, we should wonder and worry and think about, how did we get to this place and what are we going to do about it? Now, it's really complicated why we are where we are in many ways, because we've done a better job of identifying children earlier. We identify a broader spectrum, if you will, of presentation. All of these things will increase the numbers of percentages of children who experience these disorders, and that's not necessarily all bad. There's also something, I think, culturally in many places around the world where we sort of have a much narrower view of what normative development looks like. And so anything that deviates from that, we are very quick to give diagnoses to. And in fact, many people are seeking these kinds of diagnoses often for a whole host of reasons. So there's a lot of reasons why we see these numbers and prevalence rates increasing. But I think nonetheless, it is extremely concerning. And on the next few slides, what I'm going to show you is that it's not just people sort of having these subclinical presentations or, having sort of more mild disorder, but in fact, we're seeing kids with more severe and significant presentation of MEB problems. So I'm going to show you that on the next number of slides. So on this slide, again, from the same report that I was showing you before, what we see is that in 12 to 17-year-olds in 2018 and 19, again, pre-pandemic, remember, because people often attribute a lot of the problems that we see now to the pandemic. And that is, in fact, there is some truth to that. But many of these problems took root long before the pandemic. 20% of children considered suicide. 37% had persistent feelings of feeling sad or hopeless, and 15% experienced a major depressive episode. In the United States, we know that suicide is the second leading cause of death among U.S. youth and young adults ages 15 to 24, with some differences by gender. And this represents a 41% increase in suicide rates among U.S. youth between the years in 15 to 24-year-olds between the years of 2000 and 2017. So a very shockingly high increase in suicide rates in the United States. This slide comes from the Children's Hospital Association, who have tracked hospital suicide, self-injury cases presenting to the emergency department. So starting in 2016 and going through 2022, which certainly does include that very big uptick that we saw during the pandemic, you can see that the numbers have continued to rise very steadily with that sharp increase around the time of the pandemic to numbers that are now almost triple what they were in 2016. Now, the next few slides, I'm going to show you some regional patterns in the United States that I think are interesting, at least to look at to understand that there are disparities and differences certainly across states in the US. So this slide looks at, and again, comes from the State of Mental Health in America. It's just came out. It's from 2024. And it looks at the percentage of youth with at least one major depressive episode in the past year. The darker the color, the higher the percentage. So that what you can see is that there's really strong regional differences in the United States. On average, about 20% of children report suffering from at least one major depressive episode, with 15% having severe impairment as a result. This is a very, very high statistic to see that 15% of children are experiencing depression with significant impairment. And again, you can see that there's a really big range across the country. And you'll see as we look, and I'll explain to you a little bit of maybe trying to understand some of those patterns. In this one, we look at the suicide rates, and you can see that there's a strong relationship between depression and suicide, but 13% of youth are experiencing serious thoughts of suicide. And one thing we do know when we look at these kind of significant pattern differences across states is that children who come from minorities are often more likely to experience suicidal thoughts. They're the highest among our Native American children and Alaska Native youth, and they're higher among the rates have been steadily increasing in African American children. And we know that our LGBTQ children are much, much more likely to experience suicidality than their heterosexual peers. Now, I want you to contrast this with what I've shown you with the percentage of children who are actually receiving mental health treatment. And in fact, 56% of youth with major depression did not receive any mental health treatment, which was defined as receiving treatment of counseling from a medical doctor or other professional receiving medication from MDE. And I want you to note that when you look at the patterns, they're almost mirroring what we saw on the previous slides. So the children with the highest rates of suicidality and major depression were the ones who were the least likely to be getting treatment. Now, we might be tempted to think it's just that there's no treatment available, and that is a very significant problem in the US, but it's much more than that. Many of these children, when they were interviewed, reported that they felt that they should be able to handle their mental health problems on their own without any help. They were worried about stigma. They were worried about the privacy of their data. And they also had no idea how or where to identify help. So there's a lot of things in there that I think are actionable. So when we think about crafting intervention, we need to think about how to help children overcome stigma, how to help children easily identify accessible services. And we can talk about that more. And I should have said at the beginning, I hope in the questions I'll be very keen to hear about the initiatives that are that are happening in Singapore and the concerns that all of you have for the children of your country. Now, lest you think, oh, well, it's those Americans, you know, they're whatever. They've got all sorts of problems. I want to show you that, in fact, what happens in the United States is really mirrored across the world. So the World Health Organization has looked at the global mental health statistics of children and have found that 1 in 7, 14% of 10 to 19-year-olds experience mental health problems. And just when we think about this in terms of numbers, it really it means that more than 160 million youth around the world are experiencing significant MEB problems. These statistics are highest in the Middle East, North Africa, North America, and Western Europe, with a substantial number of adolescents dying from suicide every year, many, if not most, being unrecognized and untreated. And this accounts for about 15% of the global burden of disease in this age group. Now, this slide, which is a little difficult to sort of suss out, and it's not so important to do that, but what it shows is the sort of, if you look across regions, sort of the percentage of children by gender who experience MEB problems in children 10 to 19. And I don't know if you can see my pointer, but that's where South Asia is. So you're sort of in this group, kind of, if you will, in the pack. And on this slide, sort of showing the world, sort of somewhat compatible with statistics from around the world. And that if you look on this slide on the right, it shows by age groups, there's kids from 10 to 14 and 15 to 19. And what I take home from that slide is that these problems start early. By age 10, the prevalence of MEB problems in children is already quite high. So in many ways, when we think about points of intervention, I'm going to talk about this in so much more detail. We need to be thinking early, early, early. We cannot wait until children are 12, 13, 14, and they are already presenting with significant symptoms. We need to start going back much earlier and thinking about the roots of these problems and how can we tackle these things early on in life to ensure that we can reduce these kinds of numbers. So that's where we're heading now. And what I want us to talk about is the science of adversity and resilience. So we're going to do a little bit of looking at some science, and then we'll sort of move through trying to figure out by the end of this talk a little bit about how can we ensure that our children are going to grow and thrive and do well. So I want to spend a little bit of time on this slide because there's a lot happening here. This slide shows this interactive framework between genes, environment, and time, and sort of this complex interplay between the three of these that really shows how when things are going well, we can promote resilience in children, but when things are not going well, the biology of adversity. So we're going to go kind of around the bend and look at environments first, genes, and time, and sort of look at what that results in. And as you listen to this, start to think in your minds, what are the actionable things that we can be doing to really help and influence, children's promotion of resiliency? All right. So again, when things are not going well, we'll start with adversity. This complex interplay can lead to disorders of physical and or mental health problems, and also to sort of intermediate problems, emotional dysregulation, higher inflammation, metabolic dysfunction, adrenocortical reactivity. And we know that in this list, which you can see, I hope you can see, ACEs, poverty, racism, violence, access to resources, we must include and in fact highlight responsive or unsupportive and unresponsive caregiving as really important environmental factors that have a very significant impact on children's development. What we know about environments is that about half of those who sustain environmental exposures such as these exhibit some form of developmental psychopathology in adulthood, 1/2. And 1/3 of adult mental health disorders are attributable to ACEs. So what I think we need to understand and take from this, and I'm sure this is review for many of you, is that these events that happen early in childhood, right from the moment, honestly, even before a child is born, have a long-lasting reach. And so when we think about intervention, we sort of have to think about investing in young children to ensure that they are not only healthy children, adolescents, but also healthy adults. All right, so now let's move on to genes. And you can see there's a number of different ways that genes can exert their effects on child development and on risk for both resilience and adversity. One is, so individuals with certain genetic variants actually alter or create their environments. So for instance, when we look at children with varying temperamental types, children who are born with more flexible, less reactive temperaments often are easier to parent. Children who are born with more reactive types of temperaments may be more difficult to be parented and have parents that have a more challenging time with them. So certain kind of endowment, if you will influence how you shape your own environment. Number two is certain environmental influences are apparent only among individuals showing a particular gene variant. And I'm going to show you one example of that on the next slide. And then lastly, environmental exposures regulate or calibrate gene expression through things like epigenetic processes, things like methylation. So genes have a very complex way of exerting an influence. And then lastly, we look at time. And I think this is a really interesting area because many of us have been trained to think of these sensitive periods as being very fixed, not malleable. And what we're learning is that, in fact, that's not really so true, that these kind of long-held notions of very fixed critical periods may not actually be true, and that in fact critical periods can be extended and they can also be prematurely closed. So what we know now is that significant adversity can actually accelerate the opening and premature closure of critical periods around the maturation of fear circuitry in animal models. And I'm going to show you that in a few slides. And what we want to understand is that when we close those prematurely, we may end up kind of codifying some very unhealthy patterns about how we understand fear and reactivity. Now, you can still also think there's also evidence that once something is closed, it can be reopened. So we should never think that, oh, now we're past early childhood, it's all too late. Some of these critical periods can be reopened, but recognize that the later we do it, the higher the cost, the more effort that is needed. So all of these things, environments, genes, and time, come together in this complex interplay that will result in a range of different physical and mental health outcomes: learning, behavior, adaptive skills, stress reactivity, inflammatory and immune balance, metabolic balance, and organ architecture. So again, just remember, it's not only MEB problems, it's really physical health as well, often have their origins in the complex interplay between this gene, environment, and time framework. This slide simply shows that as you've listened to me, what I hope that what you're thinking is that we cannot use a one-size-fits-all model for children, because clearly it doesn't work, because clearly each individual has a very complex interplay between the variables I showed you on the last slide. And this slide really talks about that, this differential susceptibility hypothesis, that there are some children who are, dandelions. You can plant them anywhere, that you can expose them to high levels of adversity. They have certain genetic endowment, certain makeup, certain genetic, certain genes and alleles that they will thrive. Now, you may not feel like the dandelion's the most beautiful flower, but boy, oh boy, what a resilient, tough little flower that is. On the other hand, the orchid, which you might say, wow, what a beautiful prize flower, needs so much more susceptible to the environment in which it is being grown. Wrong environment, you don't get the beautiful flowers, but with the right care, a tender care, a very specialized environment, you get the orchid. And so what we know is that some genetic variants confer vulnerability to environmental stimuli and greater sensitivity to positive environmental conditions, with one example being things like the dopamine and serotonin transporter genes. So again, hold on to this idea of individualizing the kinds of interventions and care that we provide to children, families, and communities. So now let's turn our attention to the concept of resilience, because that's what we're really here to talk about, isn't it? Is we understand now the things that can make life vulnerable or more healthy for children. But let's talk a little bit now in specific about resilience and the concept of flourishing. So what is resilience? Okay. People have looked at resilience across many different kinds of fields, not just in human beings, but environmental science, family systems, economics, all of these things. It's the ability and the strength to withstand a given level of stress without a loss of function. the capacity to adapt to adversity, stressful life events, and significant threats or trauma, but to recover from these disruptions in a reasonable time frame so that we can experience the stress, manage the stress, and come back to homeostasis and a steady state. I want you to notice I am not talking about that resilience is not about never experiencing stress. It is about experiencing stress and being able to adapt to it and to recover from it in a healthy way. It's about building a muscle that allows you to experience stress in tolerable, manageable ways and to build those skills. So when we talk about the science of emotional regulation, which is really about how we build resilience, there are key regions in the brain that are involved in that emotional regulation and fear response. And what you can see is we talk about the amygdala, the hippocampus, the nucleus accumbens, part of the basal ganglia, very related to reward, experience of, rewarding part of the brain, the anterior cingulate cortex, and the ventromedial prefrontal cortex. And what we can see is that these things develop from a subcortical level up to more, cortical structures being involved. And what we know, again, is that adversity, when children experience adversity or human beings experience adversity, those links between those subcortical structures to those higher level structures like the cingulate cortex and the ventromedial prefrontal cortex become weaker links. They're not stronger links. So you end up becoming much more dependent on those subcortical structures. And we know as children get older that there is more growth of those prefrontal cortex, it comes more online. So when you think about things like, how a 2-year-old behaves when they are stressed and when they experience, have emotional reactivity, for all of you who have 2-year-olds or ever had a 2-year-old, they're really like, these are all like subcortical. They're all sort of amygdala, if you will, high levels of reactivity. But as we get older, when things are going well, something changes. And let's talk about what it is that changes. What changes when we start to have more, if you will, frontal lobe impact is that we can start to look at things that we see as fearful, possibly in a different way. Now, look, if your house is on fire, you should always react to that. That is not a time to sit back and say, maybe this isn't really such a scary thing. But there are a lot of times where we can have the opportunity and the ability to reappraise things that are coming at us and be able to evaluate with a much more contemplative and reflective way about the kind of things that we are potentially misinterpreting as kind of fear-triggering events. So let's walk through this. For instance, managing anger. Instead of getting caught up in angry feelings, we can step back and we can view the situation objectively, turning stress into challenge instead of seeing things as a threat. So it's about re-understanding what is a true threat, thinking of things as more of a challenge, improving relationships instead of reacting to someone's actions with anger. We can step back, we can reappraise, we can rethink, we can see things from their perspective. And when we have this ability to appraise things with a more careful, reflective eye, we improve physical health because we reduce stress on one's body that can lead to better sleep, immune system functioning, and cardiovascular health. So what we're really talking about here is the concept of really developing good self-regulation and being able to look at things with a more nuanced perspective. So when people have looked at things like, well, what does it really mean to be resilient? What does that really mean? What are those factors that human beings have? Ann Maston from the University of Minnesota has done a lot of work in this area. And what she's looked at, she looked across a lot of different areas of science. Individual looks at literature on resilience, family resilience, community. Sciences that were not connected, they all came up with the same basic list of what it means to be resilient, the characteristics, and these are them. Having connections and close relationships, having rituals, routines, and traditions, self-efficacy, problem-solving and flexibility, self-regulation, a motivation to succeed, optimism and hope, and having meaning and purpose. Now, we often make the mistake, honestly, of thinking a few things. Number one is that these are sort of built in. Well, you even have these or not. we can help people build this into their lives. When we talk about using a strength-based approach to care, we are often talking about asking people, hey, what is it that gives you meaning and purpose in life? How can you find meaning and purpose? What makes you feel optimistic? Now, there are times where people may not feel these things, but we can help cultivate these things in children, in adolescents, and in adults. Let's look at an even bigger concept, and that is this concept of flourishing. Flourishing is really, resilience, we said, is about being able to manage stress and kind of, if you will, bounce back from that fairly quickly. Flourishing is really about engagement, positive relations, positive emotions, competence, and self-esteem. In the National Survey of Children's Health, 3 questions were asked for children. Parents answered these about their children 6 to 17 years of age. 1, does your child show interest and curiosity in learning new things? Does your child work to finish tasks he or she starts? And does your child stay calm and in control when faced with a challenge? And those 3 questions were designed to tap into this concept of flourishing. Now, of concern, only 60% of children in America ages 6 to 17 years met all 3 criteria for flourishing. And I want you to notice when you look at those state-by-state variations, what you can see is in the children who had, who were not really, that there is a lot of significant challenges across the states in terms of who is considered to be flourishing and who is not, with sort of the states that are showing where kids are least likely to be flourishing were also the states where kids had the highest rates of depression and suicidality. Now, they also looked at, in the National Survey of Children's Health, they created a family resilience and connection index that included 6 items. When your family faces problems, how often are you likely to talk together about what to do, work together to solve our problems, know we have strengths to draw on, stay hopeful even in difficult times? And then parents were asked how well they can share ideas or talk about things that really matter with their child and how well they think they are handling the day-to-day demands of raising children. So 6 questions. And what they found is that 45% of families had a 0 or 1 on the family resiliency and connectedness score. So a very disturbingly high number of families showed low resilience and connection. And what they found was that the higher the rate of family resilience, so 2 to 3 or 4 to 6, children were 2 and almost 4 times more likely to be flourishing. So let's now look at this in a kind of complicated way. All right, there's 3 things going on this slide. On the y-axis are the percentage of children who are flourishing. Again, remember, there were those 3 questions. To be flourishing, you had to have a positive answer to all 3. That's child flourishing. On your x-axis, we have the number of ACEs. So it starts off first, we have all children, 0 ACEs, 1, 2 or 3, and 4 to 9. And then in the bars, the blue, the orange, and the green is looking at family resilience and connectedness score. Remember, that was out of 6. So blue is 0, orange is 2 or 3, and green is 4 to 6. So here's the take-home points. Number 1, as the number of ACEs increases, as you can see, as it goes from, to 4 to 9, there's less, children are not flourishing as well. ACEs are really not good for children to experience. That's our bottom line. However, when we look at within each distinct category of ACEs, the rates of family resilience and connectedness, what you see is this very clear relationship in terms of as the amount of family resilience increases, so does child flourishing, even when kids are experiencing a significant number of ACEs. So what I want you to pay attention to also is just look here. When there are children who are experiencing anywhere between 4 to 9 ACEs, what you can see is that when there is a high level of family resilience, that's the green bar, 30%, these children are actually, there's a higher percentage of children who are flourishing, 30%, than in fact when you look at children with no ACEs, but very little family resilience, 26.8%. So family resilience and connection plays such an important role in exerting a protective effect on children. And we need to think about that as we start to think about what interventions make sense. And that's what we're going to talk about for the rest of this talk. So the first thing we have to think about is whenever we talk about interventions, we've got to think in a systems-wide way. We've got to start by looking at individuals, families, community, cultural, and society. What is the dose or exposure, developmental timing, individual differences? What is the availability of close, nurturing relationships, parental health and well-being? Do the communities have safe schools, caring neighborhoods, available supports, and an infrastructure for people to obtain supports when they need them? Remember those kids who I told you about who said they had no idea how, where to even get help when they needed it? And culturally, we need to pay attention to our marginalized communities. We need to help people form cohesive cultural identities and make sure that there are available cultural institutions that will serve the needs of people. And then as a society, we need to make sure that we have an equitable distribution of resources and responses for people. So now I'm going to spend the rest of my time talking about these 4 types of interventions that I think we can think about to ensure that our children are going to be okay. Because I'm going to tell you, I really don't think our children are okay right now, but I don't think that needs to be a fixed thing. And I think that we need to work hard and think about how are we going to invest our time and our resources into ensuring that our children are okay. So we're going to talk about screening to identify children, support responsive and nurturing relationships, strengthen core individuals of individuals, and implement policies that prioritize relational health. So we'll start with screening to identify children early. So I'm showing you something that is not quite in publication yet, but that I hope will be. So I authored the paper that Shang-Chi had referred to around promoting optimal development and screening for behavior and emotional problems. And we're in the midst of an update of that paper. And this is what we are going to be advocating for. So you're kind of getting to see what we're advocating for ahead of its publication, which I hope will be somewhere within the next 6 to 9 months. But what I want you to take from this is simply these facts, without going through this in overly large amount of detail, is that we need to start screening children early, immediately, at birth, beginning with looking at things like maternal depression and regularly and routinely screening children for MEB problems that, as kids get older, includes anxiety, depression, and suicide screening. We need to get caregivers completing screens, and we need to include child self-report when children are able to, based on their cognitive and literacy level. Reminder, screening is not about evaluating children who present with problems. It is about screening children who are undetected. And again, I just want to drill it in. We believe that we should be screening children beginning essentially at birth and yearly until the time that they leave childhood. And some people say, well, how can you screen? Wait a minute, yeah. Okay. Some people say, what, really, you want to start screening children when they're 2? And the answer is, you bet we do. So this is one slide that looked at behavior problems in low-income children in pediatric primary care. Kids were screened from ages 2 to 6 every year. Now, the good news is that most kids fell into this low stable range. They didn't have problems. They continue to not have problems. But I want you to notice something. There's a group of children who screen high, who continue to screen high, and a group of kids who screen low when they're 2, but have a steadily increasing rate by the time they are 6. There is very strong evidence that says that these children who have Early presentation of problems will continue to manifest problems, will ultimately be diagnosed with things like anxiety, ADHD, bipolar disorder, depression, etc. When we start early, we have such a stronger opportunity to prevent those more significant and long-term consequences. Now, people say, but there's no good measures to screen children. There are. There's the ages and stages, social and emotional, something called the SWIC, which is the Survey of Well-Being in Childhood, the Pediatric Symptom Checklist, the Strength and Difficulties Questionnaire preschool version, which I understand is being used in Singapore, and the Early Childhood Screening Assessment. I'm going to go through these very quickly because I really want to focus on some other things, but I put up on here that these are some of the screens that are available for young children. The take-home messages are the following. They're brief. They take less than 5 minutes to do. Many of these are free and in the public domain. They are not exceedingly time-consuming to complete. They can be completed before a visit. They can be completed during a visit. They are not very time-consuming to do. They have some good psychometrics behind them to indicate that certain scores will indicate that a child is at risk and it should be followed up. The strengths and difficulties, which I said, as I understand, is being used here in Singapore, can be used in children as young as 2 years of age. So I think that we have to start wrapping our heads around screening children regularly, often yearly. And we can talk more about where that should happen, who should hold on to those screenings, but it should be happening somewhere, and quite honestly, in a well-coordinated system, so that it's my belief that these should all be going back to the medical home, no matter where they're being screened. The next thing we want to talk about is supporting, nurturing, and responsive relationships. And I have to tell you, if you're with me at all on this talk and listening, you know it is all about the relationships. It's just all about the relationships, that it is imperative that we are promoting safe, stable, and nurturing relationships because they are the bedrock and the key to healthy mental and emotional development. So what are safe and stable, nurturing relationships? They are those that are safe and free of physical or psychological harm, that are stable, where adult is dependably there for the child, and they are nurturing, so that children's physical, emotional, developmental needs are sensitively and consistently met. Safe, stable, nurturing relations buffer adversity. I showed you that with that slide that looked at flourishing, that even children having significant adversity, when there was good relational health, it buffered the impact of adversity. Because we know what happens in childhood, I hope I've convinced you, if you didn't know already, that what happens in childhood certainly does not stay in childhood. So here is the next slides are some very simple interventions we can be thinking about how to use and promote. And I think you all are doing a lot of these things. And so I'm just going to be reinforcing some of the things that you're already doing. Number one is we need to introduce emotional coaching to parents early. We often put a huge premium on introducing sort of all these cognitive skills to kids really early. They should learn all these things, colors, numbers, facts, I don't know. And we don't always put a big premium on this. So we need to help people know early on, be aware of your child's emotion, recognize emotion as an opportunity for coaching, connection, teaching, help children find words, language to label their emotions, communicate empathy and understanding, and set limits and problem solve. Number two is we must support playful parenting. I hear many parents will say, but it's just playing. It's such a waste of time. They could be doing, I don't have time to play with my children. Play is the language of young children, and play should be active, engaging, meaningful, socially interactive, iterative, meaning it grows. We praise the process, and honestly, it should be joyful. This is how children learn. This is how children learn to regulate. This is how children learn that their worlds are safe and predictable and caring environments. I'm going to mention this only to say that we want to encourage that in every day, families find an opportunity to spend what we call special time with their children that is planned, child-led, short, intentional, technology-free, and consistent. And when sometimes I say to parents, do you think you could find 5 minutes in the day, 5 minutes to just Sit with your child and play doing something they like. A lot of parents will tell me, I don't have time for that. Time is a funny and elusive thing, because there are times where you would say to that very same parent who tells you, I don't have time, who's sitting and scrolling on their, the phones and watching silly videos. But this is intentional and it takes effort. It's effortful time, but it is also joyful time. And if someone tells you, well, I don't have 5 minutes, what I ask people is, what do you think you have? Well, I think I could find a minute. Great. 1 minute. 1 minute that you turn and your child has your full undivided attention. And often it's so reinforcing for families. They enjoy it so much that all of a sudden it grows and it blossoms. And when things are not going well, particularly for kids who are having a lot of irritable, externalizing behaviors, there are evidence-based approaches that we should be tapping into for young children: PCIT, parent management training, Triple P, positive parenting program, and things like the Incredible Years. All right, I'm watching our time, so I'm going to keep us moving here. When people and children and our adolescents have manifested already these problems, we need to strengthen the core skills of individuals. And absolutely, we need to help children get connected to therapy. And absolutely, we need to use psychopharmacology when it's needed. But what I want to focus on for these next slides is that we also need to think about the other things that are surrounding children's lives that we need to think about strengthening. Number one is we need to promote exercise and physical activity. Exercise of varied impact can have there is such an emerging literature that these things can impact anxiety and depression, body image, substance use, energy, self-perception and self-concept, and overall stress levels. And there's really interesting and exciting literature that talks about the neurobiology of exercise, that regular exercise may be associated with changes to modulation of neurotransmitters, activation of trophic factors like brain-derived neurotrophic factor. These are things that promote synaptic plasticity. They're important in memory. They're widely expressed throughout the brain. They help neurons grow, survive, and mature. When we think about it, remember what I was telling you, when kids who have experienced a lot of adversity, and there's poor, weak connections between those subcortical and higher level structures. Things like this, I'm not saying exercise is a cure-all, but I think when we think about what are ways that we can help to develop more synaptic plasticity, let's not forget that this is one way. Reducing cortisol reactivity at baseline and helping to develop longer telomeres, which have been associated with longevity and healthier functioning. Number two is promoting mindfulness. Mindfulness is simply about paying attention to your life here and now with kindness, gentleness, and curiosity. And it's about helping people understand, well, we don't have to just pretend we don't experience a feeling, just like we don't have to, resilience is not about not experiencing stress. It's about learning how to sit with emotions. It's about learning how to sit with them and developing that kind of ability for cognitive reappraisal. That is what happens when we employ strategies like mindfulness. And this study that came out in 2023, this was not in children, but I think it's an important thing. This was 276 adults were randomized into a non-inferiority design where they compared mindfulness based stress reduction and escitalopram, and what you can see is the results were the same. So what we know is that the use of medication and mindfulness may actually exert very similar effects and have similar impact. And lastly, on this one, we know we need to reduce the use of phone and social media use. So probably many people here are familiar with the book that just came out that Jonathan Haidt wrote, The Anxious Generation. And what Jonathan Haidt said was, I think, a couple of really important things. Number one, no smartphones before high school, no social media before 16, and phone-free schools. But he also said that we need to combine this with more play and actually more responsibility in the world. One of his biggest points that he's made is that we've allowed children to wade into this highly unregulated area of social media, but in their quote unquote real world, we kind of over-constrain them. We do not allow children to make mistakes. We do not allow them to take risks and assume responsibility. And he's saying we've got that all wrong. We've got to increase their ability to take responsibility, develop autonomy, and reduce their exposure to social media. And then lastly, in this, of course, we need to think about improved nutrition, adequate sleep, and exposure to green spaces in nature. And there's some really interesting literature that's starting to emerge looking at the impact of that actually on neurobiology. And lastly, we need to look at policies that prioritize relational health. So we need to think about, do our policies for young children prioritize relational health? So we need to develop layered interventions that are tailored to risk, looking at primary, secondary, and tertiary prevention. We need to prioritize early relational health, flourishing, and resilience as our key metrics. Every time we do these kind of any intervention, we should think about what are our key metrics and how are we going to measure them? We need to identify those social drivers of health and relational barriers that can lead to toxic stress, all that environmental stuff I showed you earlier, and interfere with child and family well-being. And we must create policies that work across systems of care so that we do not operate across silos. And I'll tell you, I think Singapore is rather remarkable in being a fairly small country, that you really have the capacity to create policies that really can reduce siloed care. And with that, I will thank you. I am delighted to be here, and I'm looking forward to having some conversation and some questions.
Thank you, Carol. Thank you so much. I think our audience has now fed us with many very good questions. And because we have limited time, I'm going to extend maybe this webinar till about 9:05. Okay, so we can have as many questions as we can take. So as a means of sharing data from Singapore, Carol, in the National epidemiological study of mental health status of the youth in Singapore, it was pretty sobering as well, because 1 in 3 youth here aged 15 to 35 actually report poor to very poor mental health. Okay, so in Singapore, what we have done is we actually have come up with a national mental health and well-being strategy, and I can share that paper with you over these few days. And there are actually this policy-wide systemic changes that we're going to do. And like you said, they will be working on the primary, the tertiary, as well as the secondary preventive type of services, as well as creating better mental health literacy. So I have some very interesting questions here. Now, one is, we actually talk about the epigenetic influences. So the question asks, if a child had very, very bad, terrible first 2 years of his life, are these biological determinants able to be reversed? Is there hope for this child? And we know we work with a lot of children in adversity, right? Easier. Yeah.
The answer is absolutely, 100%. It just, the more we, our goal should always be to reduce adversity when we can, but we can't always. So the answer is, again, when we looked at those critical periods, and I think this is a great question, I'll tell you why, because we should never, ever give up on children who have experienced adversity and who actually may present with very significant challenges. However, what we know is that when we provide things like improved relational health, honestly, even relationships with other human beings who may not be parents, but other caregivers, teachers, therapists, interventionists, more safe and predictable environments, when we help children through therapy to develop more of those self-regulatory skills, it is 100% that we can improve, children's well-being, and that children can do very well. Just know the older children get, where they have not had the benefit of supportive and safe and nurturing relationships in healthy environments, the more it takes to try to reverse some of that adversity. So best to start young, but never give up hope.
Yes, I agree with you, Carol, because even when we look at challenging temperaments in some children, there's some biological wiring towards those types of temperament characteristics. But the research supports that if you teach good executive function skills, emotional regulation, ability for the teachers and the parents to support and meet the child with a good temperament fit, they could actually do well, despite them being wired to have more challenging temperament traits. So I agree with you, and that question was a good one. Now, this is one that will evoke a lot of conversations.
Okay.
Why are children struggling so much? Because it's difficult to believe that our genetics, our brains have Not really changed radically, though Jonathan Haidt says otherwise because social media is doing something to our brains. I agree in part, some of that. And our environment has actually improved. Housing has improved, education has improved, and yet our youth are very miserable and are more than ever so. So why do we all as community think so?
I think it's a good question. I'm going to tell you, I'm not sure I know the answer to that. I think, I think it's a great question. Is this just about, that we're doing a better job of detecting it? Is this just about, and the answer is, I don't think it's just that. I think as the question said, the children seem to truly be more miserable. It's easy to blame it all on social media. I think social media plays a very important role. I think there is also something, and it is, I feel like I sort of alluded to this in the talk. I think there has been over time, and the person who asked the question can weigh in on this, and certainly you can too, Shang-Chi. I think our sense of community and connectedness, as we see, it's not just the content of social media, but that there has been that our sense of community and connectedness has kind of decreased over time. And it's funny because as we're quote unquote more connected through technology, we are less connected as human beings. And I think that there is something there that plays a really important role in people feeling disenfranchised and disconnected from others.
Kara, I think I agree with you because in Jonathan Haidt's book, he said we bubble wrap these children and we threw them into kind of a fantasy world. And the parents don't know what they're reading, what they're seeing. The usual digital parent, we've shifted to digital parenting, right? But then yet another child psychiatry says that social media is kind of like the perfect storm for mental health disorders because it promotes quite a lot of the two mental health, the anxiety and the addiction. The need to check, to be affirmed. So I think I agree with you that in part we are connected digitally, but we are not experiencing the real deep human connections. And they feel lonely. The youth
Lonely.
lonely. And this is what's coming out from quite a lot of mental health studies. So one good question
Let me just say one more thing on that, Shang-Chi, and then let's go on. I want to get as many questions as we can. But there was some studies that looked at who are the kids who did best during the pandemic. And what it looked like was kids who had connections to some kind of community through religious organizations, through, social organizations, but through some kind of organization where they had a sense of connectedness to it. These are kids who fared better. So to me, there's something about, again, relational health, not just with parents and caregivers, but with communities as well. Yeah.
Also interpersonal and, teaching children how to problem solve with each other.
For sure.
They lose their experience when they're on the virtual world.
For sure.
Now, this is a question and it keeps pushing up my question. How do we first build a resilient family unit? A lot of times the parents report they cannot support the children as much as they want to. Some of them are, of course, from complex multi-stress families, but even the normal families or even the higher SES families, the parents feel a little bit lost. Actually, in Singapore, the Ministry of Education came up with a parenting toolkit. It was also talking about emotional coaching, spending time with the children. What's your take on that, that measure of the resilient family? Do you think that there are further things that we can do, further things?
It's a good question. I'm not sure. Maybe you can help me, Shang-Chi. The parents said they just didn't know they don't know what to do. Just say another sentence about that, and then I'll answer.
They don't know how to be more resilient as a family together.
I'm going to be very reductionistic about this and give some very simple answers, to be honest with you. First of all, it's twofold. When parents are stressed, kids are stressed. So if parents are stressed and they're away from their families too much, and they're stressed about all sorts of things, when they have their own mental health issues, that is a huge barrier to being able to be an effective parent. Most parents want to be effective parents. So we need to take care of parents. We need to take care of adults to make sure that they have the ability and the availability to be with their children. Number two, here's the reductionistic answer. Honestly, it has to do with creating time with your family that is a priority, that is technology-free time, that is sort of time that we do things together. And I don't think people need to overthink that, quite honestly, but that we build in regular routines, family meals, we eat dinner together. That's a rule in the family. We eat dinner together. And at our dinner table, we don't use the phones are gone. That we spend some number of hours of every weekend, that we do something as a family, and that we codify that. So it's not a one-off. It's a regular thing. Kids get used to it. Are kids going to push back on it if they're very used to, all this other stuff going on? Sure, they will. But I think we can build in routines and rituals that are about enhancing and building relationships and that are joyful. It doesn't have to be, it should be fun. It can be fun to parent your children.
Yeah, I think that joyful parenting is something that's kind of missing in the very high stressed, very fast-paced society in Singapore. So parents tell us they don't have the mind share even to think about what to do next with their kids. Okay, now this is a very good question too.
Okay.
Now, you say in the US and in the report that's going to come out as a publication that we're going to do well child visits with active screening for MEB problems, right?
Yes.
And I see that in the US, you do actually screen for that at touch points for health 8 to 11 years old. Now, in Singapore, quite a lot of the health touch points for child well-being is done by the time before they enter grade 1. What about schools taking up this wellness check-in? We do have some surveys now. How effective do you think that's going to be? And we have a question that talks about stigma and confidentiality in schools about their children's MEB issues. And how do we balance that with children coming forward for help?
Okay. So, wow, it's a big question. It's a great question. So let me start by saying, and you'll just tell me, I hope I'll touch on all the points. During the pandemic, when schools closed, we have a lot of schools that provide school-based mental health care to kids. And when the schools closed, I think that had a lot to do with why kids fared so poorly. They were highly dependent on that school-based counseling. So I think schools are an incredibly important place to be able to treat children's mental health, and it needs to be quite separate and distinct. The people providing those therapies need to be quite separate and distinct from people who are the teachers and the administrators of the school. And if kids can't feel confidential, that their confidentiality is preserved, they're not going to come. They're not going to talk. They're not going to develop you need to develop a trusting relationship. And that means it has to be private with, of course, the clear boundaries that, of course, if a kid's going to hurt themselves or something more, that there needs to be disclosure. I mean, that's sort of a standard, but there needs to be a real assurance of trust and confidentiality. In terms of schools being the places that screen, I think it's and I would extend this to schools' early intervention. I think it's an interesting thought, but one needs to think it through before you just do it, because you need to think about who is responsible and holding that information. What happens when a child discloses on a screen, something of very significant magnitude, like suicidal thoughts or suicidality? Who's responsible? I think that's an awful lot to ask a teacher to be holding that kind of, information. And I think it would be honestly very shocking for parents to get a phone call. Oh, by the way, your child is expressing suicidal thoughts when the parent has had no connection. The other thing that's missing when you only do it in schools is you do not get parent perspective. So I think there's a lot of potential, but you have to think through kind of the ethical issues, who is responsible. And me, I said it before, I am a very big believer that all of this information should not sit within one system, but should flow to the medical home, and that there is a cross-fertilization so that the medical home really is the holder of all of that information and ultimately responsible.
So, Carol, I agree with you. The mental health first aid protocol and how we actually do this in partnership with schools need to be very much tighter. People need to be trained to be able to deliver this mental health first aid. Yeah. Now we have about 2 minutes left.
Go ahead.
Let's take one last question. Now we talk about a whole systems approach to promoting resilience in the whole community. So interestingly, Carol, I know that there's ACEs, which is adverse childhood events. The other ACEs that I actually describe when I teach is also the adverse community events. About structural ableism, some discrimination, some communities being marginalized, inequities, and things like that. Now, what do you think is the real challenge as a whole community for us to do this better? Is it the engagement? Is it because that people do not know, a lack of willingness, or is it a lack of resources?
So you're talking about community well-being. Is that what you're saying?
That's right.
I mean, these are big, big issues, Shang-Chi, that honestly, if I may say, in many ways go above yours and my pay grade. These are large policies about how resources are allocated in a society, visibility of marginalized communities, access and equity. And all of these things are, I'm like very appreciative of the question, because all of these things honestly must be addressed to allow people to feel that their voices are heard, that they can access services in an equitable and fair way, and that there's pride in their communities, and that they don't feel like second-class citizens, that they don't feel marginalized. It is really, I feel like our job as a society, any society in this world, is to protect our marginalized communities and elevate them to ensure access. And honestly, is there cost to that? Of course there is. But it's also a mindset. And we can't ask people who are from marginalized communities to feel less marginalized. You can't just say, well, you should feel less marginalized. You need to show that they're less marginalized. We need to make sure that there's opportunity. We need to elevate these children and families and ensure they have opportunities. And, you know, listen, these kind of things are highly controversial in the United States, as I'm sure you know.
Yeah. But I also want to encourage ourselves not to just focus on particular groups of people.
100%.
Yeah, as a whole community. For example, I know that a lot of children from high SES families, expectations, overachievement culture, that's also promoting that sense of loss of hope or opportunities for them, because it's so complicated, right?
Can I make one other comment? Because you brought up structural ableism. I would also like to mention that it is also important that we elevate the disability communities as well, people with visible and invisible disabilities, and that we don't sort of approach these kids and human beings as being less or not as able to have quality of life, not as able to have, you know, a range of different opportunities of independent living, employment, marriage, love, children, all of these things. So I'm glad you brought that up.
Yes. Okay. We really don't have time anymore, but thank you everybody for participating in today's webinar. It was such a good session. Until we see you next time. Now, I just want to say and remind everybody that the Child Conference is happening next year in February 26 to 28. Please go into our child website to look at the details of this conference and sign up early so that you can benefit from the early bird registration discount. Until I see you again in the child webinar series, goodbye and have a good day, everyone. Thank you so much.
Look in your eyes, and I can see a life together. Standing by you.